Hi, I'm Alex Fisher. I'm an occupational therapist in the West Midlands Neuropsychiatry Service, which also happens to include the West Midlands Huntington's Disease Service, and I work in the community and in outpatients mainly.
Hello, my name is Kirsty Page and I'm also an occupational therapist. I have predominantly worked with people and families with Huntington's disease in care home environments and specialist hospital environments for Huntington's disease. I'm going to share my screen. Today, our webinar is on social and leisure. Let me just get the PowerPoint up. Okay, so we've had a couple of questions this week. It's always fantastic to have questions. And Alex and I are going to do the same process as we normally do. I'm going to talk about the two questions now, and hopefully in the body of our presentation, we're going to answer them. But we're always really happy for you to post questions and anything you want to add, any examples of what's worked really well for you is also really nice to have that, and we can share and we can talk about that as well. So first question we had was how to encourage social engagement in families with Huntington's disease. And second question, how much of a problem have you encountered with transport and using befrienders, carers to access local community leisure activities? Okay, so I'm hoping that we'll answer those as we go along, but certainly please put your questions on as well.
Whilst this is very sort of much about the disease itself, these are the reasons why, because of the disease, that things tend to change for people socially. So cognition, that's thinking, that changes. And that changes really, really early on in the disease. So you'll see that in early, mid, and late stages of Huntington's disease. Social cognition, so that's the ability to understand where somebody else is coming from. So, and to read emotions, both in other people and in and of yourself, and to think about that, that starts to change. Communication, so dysarthria, so the ability to express oneself, that starts to change, but as does the ability to think about complex language. And let's face it, we're in a social environment, in a social situation, whether that between two people or a group of people or in an environment, a busy environment. When you've got all of those things going on, you can see that social function will change. Then we've got social anxiety in and of itself, which is a thing by itself. So anxiety that occurs in social situations. You can see that that would be connected to cognition, social cognition, and communication. But it actually happens as a feature of being in a social circumstance, and people withdraw from society because of that. And then we also have anxiety in and of itself, which is a really disturbing feature, which I think we really overlook. But actually, that's really, really common in Huntington's disease. And because people are struggling to interpret their emotions, can come across as being distant and uninterested, or actually frustrated or angry around other people. So, I mean, that's really important to consider. There are also the sensory components of anxiety, the bodily components of anxiety. So for anxiety for people with HD, it can actually make their movement much, much greater. It can make all kinds of other bits, if you like, of their presentation and of themselves really, really hard. Then we've got a biggie, we've got apathy. This is apathy, this is neurological apathy. So really, really frustrating. Lots of people think that their loved ones are becoming lazy. And actually, we know that's not the case. Unless, of course, that individual wasn't relatively motivated before they developed the overt symptoms of Huntington's disease. So, sometimes this can be about, being quite laissez-faire to begin with. But this is neurological apathy. So this is the ability, or inability, I should say, to translate ideas into actions. And it's quite marked and quite different from depression. And we'll talk a bit more about that in a moment. Then we've got movement, we've got motor problems. So we've got the chorea, we've got the tics, we've got the jerks, but we've also got the impact on function that causes. So we've got to consider the environment, the access to the environment, which we say below. We've got to consider posture. We've got to consider all kinds of things. We've got to consider the way that the person might feel being looked at with their additional movements. And then that has an impact on social anxiety and so forth. So, okay. So I think we can go on to the next one. Let's go on to the Q&As. Oh, Andrew, it struck me today at our local HD support group how some HD patients have difficulty getting into the chat because of the effort involved in speaking. So they miss their turn and they can't interject, even if they might want to. Absolutely. It was a really lovely paper that I read only last week about a person, the group, they'd interviewed 10 people with HD about their communication. And the people had actually said, I get the feeling that nobody really wants to listen to me. And that's exactly, one of the outcomes is the things that you have just observed. And people do want to communicate, but we have to learn to adjust our communication to them. Kirsty, do you want to say a little bit about the identification of leisure and social activities?
Yes. Okay, so the reason we feel it's so important is if someone's unable to perhaps clearly tell us what activities they have liked in the past, it's collecting that background information, I guess. I'm thinking certainly when I've worked with people who have been able to verbally communicate what they've been interested in, it's been really important to speak to family members and friends and find out what their past interests and activities were. We talk about the apathy, and it's really difficult, and certainly in the care setting, it's really difficult for carers when they see someone who's not wanting to engage, and you can feel it's the person not choosing to, but actually it's the changes, it's the initiation and the drive. It's not the fact that they maybe don't want to. So it's really important to have a good understanding of past interests and activities so that we can bring them, we can use them. But actually what I'm trying to get across is adapt activities as well. So try and get someone's interest and then adapt. So we put there a little checklist. It's simple as for someone as a carer working with someone with Huntington's disease and not knowing them, going through with families, what was someone interested in the past, what might we be able to do again. Communication tools. So I've worked really closely with speech and language therapists, and we've looked at quite basic and also quite advanced communication tools in trying to get that information from people. Certainly what I've found quite nice is using pictures of an activity, and then if I've found that someone's engaged, I've actually liked to take photographs of them engaging, so that when I come along or someone else comes along to try and offer the activity again, you're actually showing that person an image of them enjoying it the last time. So I'm thinking about not only what activities someone likes to do, but how I engage them. What else we got on there? So that's the relative, the carer's involvement.
We've then got relative and carer support. Oh, hello. Have we got a big cough going on somewhere? That's what that sounded like then. We've got relative and carer support. So we've got care for the carer as well here, because we are asking people to do an awful lot. If you listen to what we're speaking about now, actually, who is going to undertake this if an individual has got apathy and communication problems? Because you can't have professionals following you around 24/7, unless, of course, you're in a care facility. So actually, it's really important to recognize that actually the carer needs guidance in this, or the loved one or the companion needs guidance in this. But again, coming back to, yeah, we're identifying social and leisure activities for the person with Huntington's disease, but what about their loved one? What about their companion? Let's not miss that out. Andrew, who's on here, was talking about attending support group for people with Huntington's disease and their loved ones via your specialist Huntington's disease advisor. I think that's a really, really important key for all people with Huntington's disease if they choose to engage with that and their families. And let's face it, not just Huntington's disease groups. If you can access other support mechanisms, that's terrific. And really, really should, because you feel isolated. You'll feel isolated because you have Huntington's disease and because of the impact of the HD on your ability to engage with others, but your loved ones and your companions might feel that too. So find a supportive network of people and reach out. Now, when we originally wrote these guidelines, actually, there was a thing, I think it was GPs used to be able to prescribe just going to the gym and all of that kind of stuff. So it was about health and well-being in the community. But now there's a whole group of wonderful professionals called social prescribers, and they're out there, and you can access them through your GP now because of the benefits of engaging with activity are seen as important to your well-being, regardless of who you are and regardless of what condition you have. It's that connection, that meaningful connection between you and an activity that you perhaps didn't even know you could engage with, or there were groups of people out there you could engage with, befrienders, carers, all of that. Now, my experience of that so far has been relatively little, but social prescribers have actually rung me up and said, hey, I'm working with this person with Huntington's disease. Do you know much about them? And what would you recommend that I'm on the lookout for? And so when we were advertising this today, I tweeted it out to the social prescribing networks of the UK. So if anyone's joined us, then welcome. It's these kinds of things, these small kinds of changes that need to be made to help somebody engage. As for actually accessing things like transport and using befrienders, again, if they're willing to engage with these changes and they are willing to work a little bit harder, because sometimes that's what it requires with regards to access, with regards to finances, with regards to transport, then it can work. But in my experience, it's a lot harder and requires a lot more effort. It's not just a case of handing somebody, here's an activity to go to that you might enjoy. It requires a lot more setup than that, but it is possible. I don't know if that answers that person's question though. That might not be enough detail, but perhaps if you wanted to put it in the chat, you could let us know. It's really important to understand cognition in Huntington's disease. When we talk about social activity and leisure activity, it's usually something that we enjoy. In Huntington's disease, cognition isn't affected necessarily in the same way as other illnesses or impairments that affect cognition. This affects the executive and what's called metacognition. And that is things like imagination. And imagination impacts picturing enjoyment. So what I found is that, for example, a lady who used to like going window shopping doesn't really like going window shopping anymore because she can't picture herself in the dress or the outfit or at the party she used to do when she was going window shopping. So again, as a person working with Huntington's disease, as an occupational therapist, as a social prescriber, it's really important to factor that in. Now, you can't replace imagination, but what you can actually do is you can talk about it, and you can look at people's responses to you, and you can listen to what they say if they're able to communicate it, and you can look at well-being through that way. So it's really important to say that. And I think that's why if you look at the bottom of this slide, changes in interest do occur, and that's kind of okay, because it might very well be that this person is not able to imagine the enjoyment from that initial activity in the same way. Kirsty put this lovely bit about information processing and hurry up and wait. Now, many of you who tune into the Huntington's Disease Association webinars will know that there's a gent called Jimmy Pollard, and this is his catchphrase. He says that pretty much all care planning with people with Huntington's disease should be cognitively informed, and I agree with him. And one of the things that he says is that he says, right, what you do is you set up the activity in the best way you can, and it's cognitively informed, and then you wait. So it's hurry up, set it up, and then wait, because information processing in Huntington's disease is really, really marked. So I'm chatting away 19 to the dozen here, and my apologies because I've got a time limit. But actually, for somebody with Huntington's disease, I'm going far too fast and giving too much information, and that'll end up them getting frustrated, and there'll be no enjoyment whatsoever. So it's about being aware of 10 seconds perhaps as a golden rule for one piece of information, those kinds of things, and you'll learn those. And then if you can do that, then you'll find that you reduce anxiety and agitation and the person feeling overwhelmed. Because for me, those things do tend to sort of exist in the context of feeling overwhelmed because there's too much information processing going on. And let's not forget that information processing is actually about all the information that comes into our brains and into our bodies, and then has to be processed. And then you have to have a response and come out again. So it's not just about talking information, it's about sensory information. It's about environmental. So again, think about all of those things and set it up and integrate that into your work. When you're doing this, you need to consider safety. First and foremost, we talk about a risk-averse environment. I think it's actually with folk with Huntington's disease, it's really important to think about safety. And actually, because a person might not be able to forward think and imagine the risks, you have to imagine the risks for them. And you actually have to consider those for them. And you have to talk about those with that person and not assume that they know them or not assume that they understand them. And then through talking through it and planning with them, you'll then get some sense of whether they do actually understand them or not. And then if they don't, then actually, okay, why are we undertaking this activity? Who are we undertaking it for? Actually, do we need to undertake this perhaps under a best interest framework? Then consider the way that the information is asked and offered. So a lot of our speech and language therapy colleagues will talk about cog impairment, and it's really important, communication and cognition impairment together. You can't really separate them. And I guess that's what we're saying in this slide, is actually you need to consider the way that information is asked and offered. And this is kind of like a framework. So it's not actually telling people what to do. It's actually a way that you phrase things to optimize the person's ability to engage with you. So Andrew, again, he talked about HD support group and people with Huntington's disease kind of being overlooked. So therefore, okay, let's consider that. Let's set up a framework in which that they can engage. And for those of us, you know, who are busy just kind of rattling away, let's us make the adaptations and just, again, we just slow it right down and we optimize it. Meaningful direction is a sort of a way that myself and my colleagues refer to actually being quite concrete in our instructions and in our communication. And it helps the person with Huntington's disease, if you like, see through all of the noise of communication and environment. So we're really clear and we're meaningful with it, which means that we know what that person wants to do. We're not telling them what to do. We know because we know what their interests are, but we're just directing them towards it in a more concrete way. Kirsty, have you got any more to say on that?
Yeah, I think, we talk about meaningful direction. I think, we've talked about how it's difficult for someone to make plans and thinking ahead and putting all the components together for the task, and then to imagine yourself in the task. So when I talk to carers, I'm, say to them, rather than saying to someone, would you like to come out in the garden? We know it's a nice day. We know once I'm in the garden, we're going to feel the grass, we're going to have a drink, and we're going to talk about the sun and how it feels to be outside, rather than going in and saying to someone, would you like to go in the garden? Meaningful direction, we're taking away all those components of having to plan and organize the activity. So we're asking in a really simpler way. So I would go in and say, come with me. Here's your wheelchair, sit in the wheelchair, breaking it down, or look out the window and talk about the day and break down what's happening, rather than making it asking a question which takes so long for the person to interpret and work out what they need to do next, such as getting up out of bed, finding shoes, finding a sun hat if it's a sunny day. And when I see that done well, it's beautiful, but it's quite a skilled way of communicating with someone. And I think, carers and family members who do it well take it for granted almost, what a skilled approach. I know when you listen to Jimmy Pollard, he gives some really nice examples of the information process and how to get it right. But I think we can't say enough how important that is, the way we
agree.
verbally communicate, or we bring items in to cue the person in, breaking down an activity into smaller steps. And it might be the person's not completing all aspects of that social activity or the leisure activity. Just being out in the garden and watching what's happening is a social experience and a sensory experience.
Yeah, definitely. Yeah, I couldn't agree more. I think this is key. It's really interesting because when I ask people to be meaningfully directive, and I explain what it is, they'll actually feel that we're taking away from the individual, but actually what we're saying is no, absolutely not. We are optimizing and empowering the individual. And a colleague of ours in Holland filmed something beautiful where she actually managed to get a person down from actually 2 care staff to actually 1 care staff by using this kind of technique. So it's really, really important. Psychological issues. We can't ignore the elephant in the room. This is really, really important. And it's, again, typical of Huntington's disease. There's this interaction between all of these domains. So actually we need to look to see whether there's anxiety going on, whether that's innate to the illness, or actually is there something else going on? And can that person perhaps engage with psychological therapies to manage that anxiety, which is perfectly possible. And the HDA had a really, really good webinar on a number of weeks ago with a couple of psychologists who I believe were talking about that very thing, and actually engaging with psychological therapy. And again, it needing to be adapted, but it's perfectly possible. So anxiety can occur for sometimes for reasons of change, as we've put here, And okay, so what's going on? Let's go back down, let's drill back down to basics, because again, in Huntington's disease, because the brain becomes quite fixed and quite rigid from earlier on, actually has change happened, we're not aware of it. Actually, is that about social change? Should we be shifting this or not? Lots and lots of questions. But anyway, we can't ignore it, because that might be the thing that we need to leverage in order to get the individual more socially active if possible. We should be managing change through planning, uses of diaries, so that actually takes away the pressure from the individual in actually organizing themselves. Because let's again come back to basics in the fact that a person's ability to plan and organize and imagine and think forward is being lost. There's a little bit of an addendum to that, which, as we've said further lower on, actually, is managing information through not giving information, managing change through not giving information in advance. And you actually find out which one works best when you try it, because one will cause extreme anxiety and the other will be like, okay, you've not had a chance to think, we're going to do it right now. And you just have to find out, unfortunately, which one works for the individual that you're working with. In my experience, usually it's managing change through planning, but for some people it's not. So just be aware of that one. Grading the activity, not necessarily doing the whole activity, breaking the activity down. As Kirsty said, sometimes it's just about being in the company of others, or it's just about sitting in the sunshine with a hat on. It doesn't have to be productive in the same way that you and I might consider an activity. Activity doesn't have to be provided 24/7, because that's overwhelming. And when did that happen anyway? So it's all those kinds of things. Positive reinforcement. You don't have to be going out there going like today. I don't have to be saying to you, wow, the sun's shining, even though Andrew's saying it in Plymouth, because it's obviously true. Wow, the sun's shining, and actually it's grey outside. It doesn't have to be that jokey. It has to be, my goodness, you're doing really, really well. I understand that this is difficult for you. And you just have to be gently just reassuring. And then other people being realistic. The amount of pressure that we place on people to achieve goals can be huge. Let's think about the pressure that we place on ourselves. I know I place a huge amount of pressure on myself to achieve stuff. And I'm totally unrealistic with my diary. Kirsty knows this. So let's be realistic with the individuals that we're working with about what we can achieve. We can always build on it. We can always do more, but we shouldn't be, it's like New Year's resolutions. We shouldn't be going for losing a stone in 2 days. We shouldn't be. We should just be realistic and gentle and kind and compassionate.
It probably doesn't quite fit into psychological issues, but I'm always surprised how tiring an activity can be for someone. I've worked with want to plan going out, clothes shopping, pre-COVID, and that's a really important part of their week, but they recognise that to do that they need to rest the day before, which will mean spending half a day in bed if that's what they feel they need, to then have the energy to plan, the energy to actually go ahead with the plan of going out shopping the following day, and then the next day it's going to be another rest day. And it's the staff, again, I'm talking about care settings because that's where I've predominantly worked, and it's actually, for that person, she was quite realistic about her fatigue levels and what she could do, and it's having the staff having to buy into that as well, and vice versa. She was able to express that, but not everyone can, and not be surprised if someone has achieved something quite incredible for them one day and then not the next, because it could be really quite fatiguing. I don't know why I've mentioned that under psychological, but I have.
That's okay. I think we've leaped ahead.
Realistic.
Apathy. Okay, so we mentioned it earlier on. I don't know if you're aware, but actually this affects about 80% of people with HD. And this is neurological in nature. So it's really important to say this is not this individual being lazy, unless that was a pre-existing trait. And who's to say when that began anyway? But this kicks in really early doors. And again, it's that ability to be able to translate ideas into action. It's a lack of neurological drive. So, okay, it's different from depression. Now, the gold standard tends to be to say to an individual, are you happy? Now, that seems really, really simple, but actually, usually a person can kind of go through examples of their well-being, smiles, body language. They'll be able to say yes, or they might be able to say no. Again, looking at signs of well-being, in which case, what you do is you treat the depression first. But then, because depression can cause apathy, you then might see a change. But if the apathy is still existing, and I'm literally talking about you leave your man in the morning and you've given him a list of things to do, and you come back in the evening and he's not moved, that's what we're talking about. And it's literally because he kind of knows what he wants to do, he hasn't got the drivers, and he hasn't got the ability to translate that into action. Okay, it is associated with cognitive change. Again, some really good papers that just started to sort of recognize that it's associated with cognitive change. So it's almost like the precursor to that. What to do? So there are meds that can treat apathy. There are some, but there's not a huge amount of evidence behind them. And because aggression and agitation and irritability is common in HD, people are really, medics won't prescribe, and they won't prescribe because those kinds of meds that treat apathy also increase irritability and anxiety and anger and so on and so forth. So it's almost a no-go. So what we come back to is very similar sort of foundational principles, as in, okay, structure, routine, environment. So think about your interest track list, break it down, and actually put it in as a regular activity. And then actually, if it's meaningful, direct that individual towards it. So we've got this meaningful direction, communication style, structure going on, making sure that the environment isn't too overwhelming, making sure that the environment is set up so that that person can gain ownership of the activity that you want to achieve. So in this in the community, this might very well be about lists as large as you like next to where the sandwiches are set up in the kitchen. This might be an alarm system that goes off that directs the individual towards that with a voice to say, now is time for X. So it's about breaking those things down. And then it's hurry up and wait, not too much, not too little. And those things in and of themselves, and I was at the HDYO conference, which I think was in February, and I was listening to a psychologist talking about apathy, and these were the skills that she mentioned. So it's our psychology colleagues who are reinforcing this as well. This is really through a psychological and a cognitive lens, but bringing in all of the other bits that affect folk with HD. You were talking very much about fatigue. It gets thought about a lot in illnesses such as multiple sclerosis and other conditions. But actually, I was with a group of carers yesterday, and I was like, right, okay, I want you to move, and I also want you to think, and I want you to count down in sevens from 100. Start now. And within 5 minutes flat, they were all utterly exhausted. So I think, again, we need to really, really consider this if we're talking about social and leisure activities and optimizing engagement in those. And previously, Kirsty and I have spoken to everyone on postural management and seating. It's actually also about what's underneath our bum. Is this person comfortable? Can they maintain the position to be engaged in the activity that you're asking them to be engaged in? So many things.
we've put on that overstimulating environments, and that can be as simple as television being on too loud, people in the same room talking too loud, tea trolleys moving around, or a dog barking, just a normal, quite busy care home lounge can be overstimulating for some people. I don't think it's really hard to put a number on how important that is and how that can make such a difference to someone. A calm environment, or periods of the day where the environment is calm. It doesn't need to be, as I've already said, activity for you and I and leisure doesn't happen 24 hours a day. It's okay to have quiet times in the day, and it's really, really important for folks with Huntington's disease to have some quiet times as well. What really struck me when Alex and I went to some care homes is, in a care home environment, actually on the timetable after lunch was an hour where residents were encouraged to go to their rooms, either to lay down and relax or just to sit and have some quiet time before the activities again started in the afternoon. And I really liked that. It was seen as really, really important. Not this, we've got to have activity all day long. It's really important to have that downtime as well.
Yeah, I mean, I've been to some homes. Yeah, was that when we were in Holland? It was when we went to Holland, wasn't it? Yeah, but I've been to some homes over here, and it's quite interesting because a number of them will say to me, well, we've got to be seen to be offering activities to people. And I'm like, yeah, I know you have, but you've also got to be seen to be offering them in a very person-centered way. And that's what we're talking about here. So actually, if a person does need these breaks, then absolutely you should be facilitating that. Yeah, that's where we're going with this. I've got colleagues who work in chronic fatigue service, and they do advise people on pacing. And one of the things that they advise is that actually there are built-in breaks regularly throughout the day, so that they can recharge their batteries if possible. Kirst, do you want to talk on? This is activities for late stage HD.
I think it's really important. We've said it again and again, but all activity is purposeful, from eating, drinking, brushing teeth, getting up in the morning, to sitting, watching the TV, or actually going out outside, or joining a social group or a physical activity group, or individual activity. I think we forget that doing the housework, that's activity as well. We sometimes think of activity as it's got to be something we really enjoy. We all do activities every day that we might not enjoy, but they still need to be done. So think of all activities as purposeful, and even something as simple as getting washed and dressed. There's a lot of choice. It's still a sensory activity, and making choices about what you want to wear or what you don't want to wear. So I say that all the time. All activity is purposeful, and we talk about person-centered, and that goes back to when we were talking about activity checklists and finding out what was important to someone, what's important to someone now, and what was important in the past, so that any activity that you're planning to do with someone is important to them.
Yeah, Andrew said in the late stages, do you think the activities need to be more visual, tactile, or sensory? I think it really does depend on the individual, and I think we've now got this wonderful little OT hub set up on the Huntington's Disease Association chat room. One of the OTs was talking about, Gillian, I think it was talking about, thinking about activity in a sensory way for people with Huntington's disease as a whole, a sensory approach to Huntington's disease management. And I think that's great, because the interpretation of information includes sensory information, and we should be considering that. But actually, activities in late stage, there's a really, really good tool called the pool activity level. And it breaks down, if you like, it gives a profile of the individual as to how they may be interpreting the world and what level of activity that you should be providing and engaging them with. And within that, that will actually give you some idea as to whether you are undertaking tactile activity, sensory activity, activity with regards to proprioception, feedback, all of those kinds of things. It's a really, really great tool that can actually be used by caregivers, loved ones, companions, professionals alike. And it essentially takes this idea that you take the person without their pathology. So in other words, what that person is, who that person is, what they loved, and then you apply your profile that you've created from the pool activity level. And a person is one of about 4 or 5 levels, and it shows the levels at which they engage, and then you adjust those activities at that level. It's beautiful. It's so simple and can be really, really well applied for people in mid to late stage HD, I would say.
And I would say to Andrew, and late stage people with late stage HD probably are going to be at that lowest level, the sensory level. So imagine that plant there in the garden. Someone can still go and join a gardening activity, but I would be making that activity much more sensory for someone late stage HD. So rather than physically watering the flowers, the feel of water on their hands, smelling, us crushing up the leaves and smelling the herbs or the flowers, what we're planting. So again, thinking about all the senses, but yes, it would be more of a sensory component. I wouldn't expect someone necessarily to be able to plant a seed and water it, but they can still be involved in what's happening and the sensory components of that.
And I think that comes back to positioning as well, all of that kind of stuff, because the amount of folk that I go out and see in nursing homes, and I do, and because perhaps there's not the equipment to get that individual out, or people have become scared about moving them out into a chair, an appropriate specialist chair, where that person can actually engage in the way that Kirsty has just described. That's really important, and that's really important that we're advocating for that, and dare I say it, sometimes fighting for it, which is what we have to do, and we've addressed that previously. But then that will allow that engagement, that tactile engagement, that sensory engagement. And with regards to visual, visual cognition in Huntington's disease is affected, tracking is affected, the interpretation of information, again, information processing coming into the eyes, but actually through assessing that and through observing features of well-being, you'll be able to see that, and you'll be able to determine what you do with that individual. First and foremost, benefits. Okay, HDA are fabulous at guiding people towards and supporting people in hopefully getting the right benefits that they're entitled to, and I know that they don't stretch far, and I know people use them for their gas and electric, but it's just about making sure that they're on the right ones, and again, advocating for them so that people can use them in the best way that they can. And also making sure that actually if people can't manage their monies, because we're talking about executive function and that gets impaired, it's about making sure that somebody is overseeing that so that they've got the monies left to be able to engage in social activity. But then there are, so then there's signposting and supporting. Again, the HDA are fabulous at this, but there are other charities which I could name, but because we're doing for the HDA, I'm not going to, but we'll also signpost and support people so that you can access low cost activities or perhaps online activities, for example, physical activity, adapted wheelchair activity via Zoom, via organizations such as Use It or Lose It, Move It, excuse me, Move It or Lose It. And then arts activities are available now, and there are lots of organizations. So we've got Arty Folks, which is in Warwickshire, which is great, which people can access. But again, it's about the access to getting there. So then it's about considering the transport, wheelchairs, so on and so forth. And this is all factoring in the cost of leisure as well, and where to go to get ideas, simple ideas. So Ewan's list is a really, really good list of accessible venues, which was created by a gentleman with motor neuron disease some time ago. And I think we've put most of these on our clinical tip sheets, which are available on the HTA website, I think. I know that they need updating, but again, our lovely colleagues at the HTA are super splendid at all of this stuff. But yeah, I know this is a massive issue right here.
Yeah, I think we do. Just looking at the tips, we
no, because we wrote them.
we talk about Ewan's Guide and cinemas. Yeah, cinema cards as well. I don't know if everything's been closed, but you could get certainly carers at some cinemas could get a card to get in free, which would reduce the cost.
Yeah, and again, it's about knowing all of those fiddly bits, and those do exist, and that's why we've put them all together on those tips. So, Kirst, do you want to talk about this?
Yes. So, environmental considerations. You've just touched on it, Alex, in terms of planning where you're going. So, mobility does change with Huntington's disease. I'm not going to go into any details because of time, but please do refer to the physiotherapy guidelines on the HDA. So much evidence-based information on them about mobility changes and equipment. In terms of OTs, then we would be getting involved in wheelchairs, assistive technology as well for communication, not only communication, that's more speech and language, and environmental adaptations to use your environment. So thinking ahead, if you have got a wheelchair, thinking ahead about, can you access transport? Can you access the community once you've got to where you're going? Thinking ahead about toilets, access again. There's a national key scheme so that you can have a key to get in disabled toilets. And finally, there are now changing places, so places where there are benches and hoists for transferring on, so that if someone's unable to transfer with assistance onto a toilet, a disabled toilet, there's now changing benches, which is just fantastic. It's really important to think about that before you do an activity for it to be successful. I mean, it goes without saying, but I've certainly gone out as an OT, gone out and done a risk assessment before planning an activity, particularly if I know it's going to be a long day. There's nothing worse than having to come back early because someone needs to be changed or they can't access the toilet, or I've phoned ahead, and if someone's got diet changes, for example, a dysphagic diet, I'm planning ahead to find out what's available, or is there a microwave on site? Can we reheat food? You want an activity to be positive. We want the activity to happen again. So it's really important to put the time in before going out to consider the environment to make it a successful activity. Anything to add, Alex?
No, not really. There is no, I don't think so. No, I'm conscious of our time actually, because we could chat all day about it. Oh, look at this.
Smoking's quite a biggie, actually. So we have got 8 minutes to discuss smoking.
Okay. Sorry.
You go for it.
Do you want me to go for it? Okay.
as it's you up there, Alex.
Okay, so yes, okay, this is me with a different hair color in Holland testing out a smoking robot. So okay, now smoking, okay, it can become a thing of passion for people with Huntington's disease, because actually what we're talking about sometimes is actually this is a thing of enjoyment, and yes, we're going to include it in social and leisure, and yes, I know we're health professionals and we should actually be discouraging it, and so therefore absolutely we should be considering smoking cessation if possible. But we're talking about folk with Huntington's disease, and actually it's rather fixed and rigid, and they might want to do what they might want to do. And they might also be saying, hold on 1 second, you've taken everything away from me. You're not going to take away my smoking. So then, okay, we're kind of going, right then, how can we adjust it so that we can make it safer, if that's possible? And there are ways and means, and usually folk will engage with you if you undertake it in a sensitive fashion. So there's looking at vaping. Now the HDA have got a wonderful information sheet on what safety measures to consider if the person is able to adopt a vape as opposed to smoking an actual cigarette. And that's very much about electrical safety and charging and so on and so forth. And that in turn leads me on to talking about the fire brigade, who also have quite a lot of information. So your local fire brigade are a massive help here. In fact, I would say first and foremost, if you're working with a person with HD who's a smoker in the community, you essentially get out the fire brigade to help you out. And they also have lots of goodies and lots of freebies. So they'll have fire alarms, they'll have duvet cover. I've seen duvet covers, blankets, all kinds of stuff that the fire brigade you didn't know that they had access to will actually give out. The other thing is that actually they'll be able to do what's called a fire safety evacuation plan for the individual. And whilst that might mean that they don't get to top of the queue, if there was ever a problem when you called 999, they would know that there's a vulnerable person living at that environment. So it's really, really worth it right there. Equipment. Now, I put branded cigarettes because actually I know a lot of people go and buy their fags from a man in a pub with a dog on a string. And actually, usually those fags are the non-branded type. And that's the reason why that they're actually being sold really, really cheaply. And I appreciate there's a cost here. But with branded cigarettes, there's a little fire guard around the fag, the top of the fag, which stops it burning should you drop it, which happens a lot in Huntington's disease. And that's really important because the individual might have cognitive problems where they're unable to self-monitor. So if it drops, it doesn't actually burn as long. If it goes down the side of an armchair, it will actually stop burning if the armchair is, the furniture is fire retardant. So it's those kinds of things that we need to consider. Fire retardant clothing, different kind of lighters. So actually, again, the HDA information sheet on smoking talks about getting in touch with REMAP, who are an organization of ex-engineers who will design some really kooky ideas that the person with Huntington's disease will be able to operate safely. So it's about, can they operate the switch? How long can they keep the light on for? Those kinds of things. So you've probably never thought about smoking in such detail before, but I would encourage you to think about it. What you've got here, and you've got in this quirky little image here, is a smoking robot, which actually allows for the fag to be lit and actually therefore takes away, if you like, the danger of actually smoking a cigarette and dropping it, but you still get the enjoyment of the nicotine. And as you can see, I'm wearing a very tasteful fire retardant apron. So those can really, really help. And sometimes they've got like little sort of lip on the bottom. If the person drops a cigarette, it will actually fall down the front and it will actually extinguish in the base of the apron. And again, you can work with people very gently to get them to wear these things. In the community, it's a lot more different than that. So it's about thinking about all of these things, thinking about cognition capacity. That's usually what it comes down to. And so I've been into homes where people are no food in their fridge, smoking like a trooper, dropping it on their skin, dropping it on their clothing. And actually, whilst we might consider all of these things a choice, we have to question whether they are and what we're going to do. And actually, ultimately, comes down to it, our job is to protect people from harm. How are we going to do that? So we might have to ask some really sort of significant questions about personal choice and autonomy.